Hello, my name is Sarah Fryman Fontenot, and I will be your faculty for the American College of Physician Executives course called STARK, Prohibitions, Exceptions, and Guidance for the Future. STARK has been an interesting law for many, many years, as we will see, but particularly why this program is coming up right now is that there have been many recent changes, particularly in 2007, beginning of 2008, a number of different changes happened which made really, truly, as it says here, sweeping and dramatic changes. And so STARK always was confusing, and it's only become all the more so because of these changes. So I want to take a very logical, reasoned approach to STARK to explain what those changes are. As you see, this slide, change is in the air, and this slide will come up a number of times during my program, and that will always be a visual clue to you that we're talking about some of those changes. But the problem with the changes is they will make no sense unless we understand what STARK was before the changes came in place. So I'm going to incorporate all of that in this program, again, hoping to make it a logical, coherent explanation of the STARK regulations. So in order to do that, I want to give you an introduction to STARK. Some of that may be review for most of you, but again, I want to start at the beginning so you understand where we are now. And I'll give you a regulatory review. We need to take a detour into the whole topic of what is a group practice, because that is often an area of confusion or misunderstanding. And then we need to talk about the all-important exceptions under the STARK regulations. I'll get into reporting requirements and penalties. And last but not least, I do need to talk to you about kickbacks. As you will see, kickbacks are basically the other side of the coin when we're talking about physician self-referral and STARK, so it's important for me to incorporate that as well. And I'll end with a little bit of a heads up for what is the future, as best we know, of the STARK regulations. Okay, so starting at the beginning. In 1989, the Office of Inspector General, or the OIG, did a study looking at the phenomena of physician-owned healthcare entities. The question was, if a physician has an ownership interest in an entity, are they more likely to refer patients to that entity because they have a personal financial investment? And the study showed that that was likely to be true, or at least by their interpretation, it was true. They found that 12% of participating physicians at that time did have an interest in an entity, and again, their study showed that yes, there did seem to be an increase, an uptick of services in that scenario. As you'll see there, they were looking specifically at clinical laboratories, physiological testing, and DME. Very contemporaneous with that, there was a study in Florida State that had similar findings. So when people ask the question, why do we have STARK, it is based on that premise that with ownership you will see increased utilization, and with increased utilization you will see increased costs. And we all know that cost is very important to the government when they're looking at health care. Now this slide, let me say one other thing. STARK is unnecessarily confusing. It is confusing no matter how you cut it, but it is unnecessarily confusing in my book. So I want to take a very structured approach to how we discuss the regulations in this program. And what I do whenever I'm faced with a confusing law such as this one is to go back to those basic questions we all remember from elementary school: who, what, where, when, why, and how. And that's how all of those questions are going to be answered in the context of this program. So again, why is an easy one to take care of? It's because the government studies did show that with ownership you've got increased utilization, increased costs, so therefore that had to be controlled. Phase 1 of the STARK final regulations, they attempted to focus on the main abuse for which the STARK law was aimed to deter, which again is physician financial relationships that result in overutilization of services. So ultimately this becomes a financial regulation. Now, I've been calling it STARK, the program's name STARK, and in all fairness, that's not really its name, it's just what we all call it. Technically, STARK is the Omnibus Reconciliation Act of 1989, But the reason we call it Stark is because of Representative Pete Stark, who is, I'm sure you will know, a California representative that's been in Congress now since the 70s. Mr. Stark, Representative Stark, was a very successful businessman before he came to Congress, and this was and continues to be one of his most notable projects, or certainly one of the things that's most closely identified with him over the years at Congress. So we refer to it as Stark, but that really is a misnomer, although I'm going to continue to use it in the program because it's easier than the Omnibus Reconciliation Act, and it's also just how we all refer to the law. Now, this is Stark. Let's start again with a broad brush Stark, and that is why the brush is there. Stark says, physicians are prohibited from making a referral for a designated health service to entities in which the physician or an immediate family member has a financial relationship unless an exception applies. All of the highlighted words are the definitions that we need to go through to start putting meat on the bones of this. But before I do that, one of the misconceptions about Stark, again, is who does it even relate to? Now, as you'll see here, Stark was passed specifically because the concern in the government was about Medicare funding, and were Medicare beneficiaries getting more testing, designated health services than necessary because the physicians had a financial interest. A couple years after that, in 1993, Congress said that the same rules were also applied to Medicaid. But I want to make it very clear, it does not mean that these rules only apply to Medicare and Medicaid beneficiaries. In fact, it would be foolhardy to assume that you can have one set of practices for non-Medicare, Medicare beneficiaries that would be completely without any regulation. I don't know what state you are in watching this program. Most states also have laws regarding physician self-referral. As you will see over the course of the program, there's a number of other federal laws that tie in Stark, although they're not technically Stark regulations. So the emphasis of Stark, it is true, is on Medicare and Medicaid, or what I call the M&Ms, but it does not mean to imply that the same things that are not allowed under Medicare would be perfectly fine with your other patients. The safest way to deal with this topic is assume that these regulations are equally applicable to all your patients. You're certainly never going to go wrong with that interpretation. Along those lines, speaking of who else it might possibly come under the scope of Stark, as you'll see here, yes, again, it came under the Medicare programs, but they don't want anyone billed for these programs, for these services. That's certainly true, again, under Medicare. But again, let's just take a safe approach and say it's going to apply for to all your patients, and then you can talk to your own counselor, your state medical association, whoever in your state is very well versed in your state laws, and find out if maybe you couldn't back off from that position somewhat. Stark has been, as I said, it's very confusing. One of the reasons it's confusing is it has gone through so many changes. And this probably is not even an all-inclusive list, but what you'll see is year after year after year, these regulations have come out, often years after the law was passed. In fact, we just got phase 3 in 2008, and you'll see that the law again was in 1989. So it has been a very, very long, ongoing process. But the other thing I want you to notice in this list is that it's not always Stark. For example, a lot of the changes we'll talk about as being very recent came from the drug benefits portion of Medicare, the MMA Act of 2003. Or again, as you'll see there, the Medicare fee schedule. There's other ways that these regulations come up, and that is, again, has added to the confusion, understandably. But these most recent changes are have really added more confusion than a lot of the changes that have been over the last 10 years. I like the quote, how could the government possibly make matters worse for hospitals and physicians doing their best to avoid Stark violations in their everyday business transactions? Simple. Just take one of the most complicated sets of regulations ever imposed and change it up to 3 times in the course of a year, which is what we have witnessed over this past period of time. And again, it is trying to make sense of that is ultimately the impetus for this program.